I'm Kira Curtin, the managing editor of GenoWeb's Precision Medicine Quarterly, and I'll be your moderator today. The title of today's webinar is Biomarker Discovery and the Impact of Molecular Heterogeneity in Prostate Cancer, and is sponsored by Beckman Coulter Life Sciences. Our speaker today is Nala Sivam Palasamy, an associate scientist in the Department of Urology at Henry Ford Health. You may type in a question at any time during the webinar. You can do this through the Q&A panel, which appears on the right side of the webinar presentation. And if you look to the bottom tray of your window, there are a series of widgets to enhance your webinar experience. And with that, I'll turn it over to Nala. Nala?
Good morning, everyone. Thank you very much for the kind introduction. First, I would like to thank the organizers of this meeting, the Genome webinar, and also the team from Beckman Coulter Life Sciences for giving me this opportunity to present our research work on molecular heterogeneity in prostate cancer. So in this presentation, I would like to highlight our recent work on the understanding of the multifocal nature of the prostate cancer using the well-established molecular biomarkers to understand the extent of tumor heterogeneity and its impact on early diagnosis, and also some of the risk assessment using this information. And also I will talk about some of the new approaches that we are taking to discover some new molecular biomarkers in prostate cancer. And I would like to acknowledge that I don't have any business or financial relationship with any of the sponsors of this presentation. And I do have some ongoing relationship with AstraZeneca as an advisory board member. So, and also I would like to thank the participants via online. I understand that many people from all over the globe, and they are attending the seminar. So for their benefit, first few slides, I would like to introduce the incidence of prostate cancer all over the world, because I assume that many of the participants, you may not be working directly on prostate cancer, at least for the benefit of those people, and also for if any students who are attending this webinar, it will be beneficial to them as well. So to begin with, if you understand the incidence, the overall incidence of prostate cancer all over the world, the so-called developed countries are known to have a much higher incidence of prostate cancer. As you can see, some of the North America, and then the Canada, then the Europe, Australia, and some part of South America are known to have the higher incidence of prostate cancer compared to the most of the Asian and the African countries. But if you look at the mortality rate of prostate cancer throughout the world, it is completely in the reverse. And the so-called developed countries, the mortality rate is not that high, but whereas some of the underdeveloped or poorly developed nations, although the incidence of the prostate cancer is low, but the mortality rate due to the prostate cancer is much higher in these countries. It could be due to various social and economic and other healthcare access problems. So I think this is, I'm showing this for you to recognize the overall incidence and the death rate of prostate cancer across the world. And if you look at the individual countries where the incidence of prostate cancer, particularly in the United States, as I told you, the North America has a higher incidence of prostate cancer. Even within the United States, the incidence of prostate cancer is much higher in the African American, or in other words, the Black population, compared to the white population, which is highlighted here. And also the incidence is much lower in the Asian countries and other ones. So in all these countries all over the world, I think the prostate cancer specific antigen called the PSA is routinely used for the diagnosis of prostate cancer, to understand early, kind of detection of prostate cancer. So in the next slide, I will show you, in compared to the other solid cancer, what is the overall incidence of prostate cancer. Prostate cancer is the second leading, cancer when compared to all other solid cancers. The lung cancer is the foremost one, and the prostate cancer, about 1.4 million individuals are affected annually all over the world. And it is much higher incidence in Europe, Asia, North America, and Latin America when compared to the other countries. So this will give you a perspective of, so it is a global problem. That's what I'm trying to convey the message here. It is not only specific to any particular region, although the incidence may vary, but still there is a good number of cases in each population. So since I'm working in the United States, I would like to highlight the overall incidence of prostate cancer in the United States. According to the American Cancer Society estimate for the year 2023, the new estimates about 288,000 new cases will be diagnosed in the United States alone, which is the leading cause of I would say the leading cancer in men in the United States. But if you look at the mortality due to prostate cancer, that is the second leading cause of death in men, which accounts for about 35,000 cases in men in the United States. So with this overall incidence, both the global and in the nationwide incidence, what are we trying to, what is our research focus in this cancer? Since it is a global problem, what is new to learn from this cancer? As you know, prostate cancer is not initially a killer disease. When it is diagnosed earlier, if it is treated, it is quite manageable. But still, there is a subset of patients, they come up with a very advanced or aggressive cancer type, which is leading to the mortality. They suffer from advanced metastatic disease and they undergo disease. So we are trying to understand what are the challenges in the early diagnosis of prostate cancer, and how we can actually do the risk assessment to intervene early for diagnosis and treatment. So one of the major problem in prostate cancer, as you know, unlike many other cancer, prostate cancer is a highly heterogeneous both at the molecular level and at the morphological level. It is a highly heterogeneous disease, and it is a multifocal disease, meaning that within the prostate gland, there will be at least 2 or 3 tumors you will recognize in any given patient when they come for initial diagnosis. So our goal is to understand the clinical significance of each and every foci, not only just taking the high Gleason grade or the large tumor, but we are trying to understand, taking the entire prostate landscape together, try to understand what is the interrelationship between the extent of molecular changes and what are the clones, the individual clone that has the metastatic potential to develop into an advanced and unmanageable disease. And the smaller foci, I think most of the focus is always on the index or the dominant foci, but most of the smaller foci are conveniently ignored. But what we are thinking that is even the smaller foci with the higher Gleason grade may also carry some distinct driver molecular aberration that can be easily missed by conventional screening approach. And based on the multifocal nature and the morphological heterogeneity and the clonal origin of many tumor foci, we hypothesize that the different tumor foci may harbor distinct driver molecular aberrations, which is making it a more complex disease and difficult to manage. So I will show you in the subsequent slides what we learn by doing this type of analysis. So since we have this multifocal and a molecularly heterogeneous tumor, it may affect diverse phenotypes such as treatment response, drug resistance, and clinical outcomes. These are some of the challenges that we are facing in treating or managing prostate cancer. And recent studies, ever since the advent of the next-gen sequencing and other advanced molecular techniques, the genomic profiling identified many recurrent genetic aberrations that are specific to prostate cancer, which I will highlight in the subsequent slides. So our goal is to understand which markers, the well-established prostate markers, are correlated with the degree of tumor heterogeneity. So what we are doing is, in order to address this problem, contrary to the conventional approaches, we are using the whole mount radical prostatectomy specimens rather than just taking a sample of the prostate with the high Gleason grade or anything like that. So we are analyzing the entire prostate in an unbiased manner to understand the interrelations between the smaller and the larger tumor foci. So what in this presentation I'm going to highlight were some of the new findings that that will highlight that we show that we identified some distinct new molecular subset of prostate cancer, which I'm sure you will recognize that as a rare and a unique phenomenon for prostate cancer and how it impacts the overall kind of outcome of the disease. So with this introduction, let me move on to the next slide. So here I want to show you on the left side, if you look at, so I'm sure many of you are familiar with this kind of figure, which shows the different morphological or the Gleason patterns that are routinely used for the prostate cancer diagnosis, both in the clinic and the pathologists use this, like a 3+3 Gleason grade, 3+4, 4+4, like that. And now I think, according to the World Health Organization, they are actually doing Gleason group rather than individual Gleason grade. So although we recognize these different morphological patterns, none of these patterns are associated directly with any particular molecular marker. So although the Gleason pattern will tell you what stage the disease is, but you cannot decide based on any treatment directly, any targeted therapy or anything like that. We cannot do just based on the molecular aberrations. It will tell you whether the tumor is in the early stage or advanced stage. Other than that, we don't know much about based on the morphological classification. So based on the advanced molecular analysis, there are many molecular markers have been discovered, including particularly gene fusions involving the E26 transcription factor family of genes like ERG, ETB1, ETB4, and ETB5. These are the major type of gene fusions that are identified in prostate cancer. I think many of you may know that the H gene fusions are the first recurrent gene fusion ever identified from the University of Michigan by Dr. Aurel Chinayan in the year 2005. Until then, we don't know the incidence of recurrent gene fusions in any solid cancer, which is a remarkable discovery. Then following that discovery, there are many other findings have been identified. I was involved in the discovery of the druggable RAF kinase gene fusion in prostate cancer. So using these molecular markers, this is the first time we are able to classify the prostate cancer into distinct molecular subtypes rather than morphological subtypes. So it is not only important because all these gene fusions account for about 50 to 60% of the prostate cancer. Still, there is a subset we don't know what are the molecular aberrations, but this is a significant number, about 60% of these molecular markers. And some of the preclinical work is being done, and which clearly shows the potential that these gene fusions can be targeted with some specific drugs, like the H gene fusions we can use, like PARP inhibitors. They're not directly targeted, they are indirectly, because most of the H genes are like transcription factors, where that is challenging to develop any direct targeted therapy. There are several work is being conducted, some of them are published, showing the potential that these gene fusions can be targeted in an indirect manner. And some of the small molecule inhibitors have been developed for ETB1 gene fusions. And our work by Dr. Bushra Atik et al., they showed that the SPINK1, that is overexpressed, it's not a gene fusion, but it is overexpressed in a subset of prostate cancer that can be targeted with the antibody for EGFR inhibitors. And I was involved in the discovery of the RAF kinase gene fusion, which can be targeted by using the FDA-approved MEK or the sorafenib inhibitor. So there is a potential that these gene fusions can be eventually, although they are not ready for prime-time clinical use at present, but eventually, I think in the near future, these gene fusions can be targeted with the with these therapeutic molecules. So with that, and recently there are many other work that are published that also shows that it is not only the protein coding genes, some of the non-coding RNA like the SLAP1, the KLKP1, PCAT, kind of non-coding RNAs are also shown to be expressed in a cancer-specific manner. And although they cannot be directly targeted with any drugs, but I'm sure there will be some using the CRISPR and other methods, eventually the methods can be developed to targeting this molecule as well. So given this long list of prostate cancer specific markers, so this is the first time we can actually classify the prostate cancer into distinct molecular subtypes. So now, and also in addition to those gene fusions, when you look at the metastatic prostate cancer, there are many other kind of targetable genes have been identified, especially in the precision medicine or the personalized medicine field. There are many druggable targets have been identified, particularly when they take the initial biopsy. They are subjected for targeted sequencing to identify the specific mutations, and that can be treated with some specific inhibitors. So if the patients are not responsive to any of those, and the subsequent biopsy can be characterized for identifying some additional targets for treatment. So this is the current status of the different molecular markers that are identified in prostate cancer, how they are managed in the treatment. So with the identification of a specific molecule, as I shown you, none of these molecular markers that are identified, whether it's the gene fusions or other mutation, they are not present in 100% of all prostate cancer. Because most of the, I would say in almost all solid cancers, any recurrent aberrations that are identified, they are actually present only in a small subset. Like I think the classical example is the EML4 ALK gene fusion that is identified only in less than 5% of the lung cancer, but still it is a targetable molecule, and there are therapeutic options have been developed. Like that, I think the main idea behind discovering more molecular markers is to divide the cancer into distinct molecular subtypes and target them with some therapeutic options. So I think that is the goal of identifying distinct kind of molecular markers. But still, like I mentioned, still more than about 20 or 30% of the prostate cancer, we don't know what is the underlying genetic mutation in those cases, which I will talk more in detail in the subsequent slide. So with that, I want to highlight some of the kind of the conventional approaches, that what is being done in the clinical field to diagnose prostate cancer. So like you show at the top, I think when the prostate cancer is early diagnosed using needle biopsy, when the PSA is elevated, so biopsies are done, and they look at the different Gleason grade. Based on that, they decide. And also, if there is any additional molecular test need to be done, even after surgery, when they do radical prostatectomy, that is removing the entire prostate, they take only a sample of the higher Gleason grade. You're not looking at the entire prostate. They take only a sample and subject them for any molecular analysis. And many decisions are made based on that. And also for research and other purposes, people do construct a tissue microarray, which again take only a sampling of the entire prostate. So because I'm highlighting this mainly because, as we know, almost about 90% of the prostate cancer are multifocal disease, meaning that more than one tumor foci are present. So if you take only a sample from one tumor foci, which you think that which is high Gleason grade, which may be the biologically important tumor foci, we are conveniently ignoring a large chunk of the tumor, which we don't know the biological importance. So for that reason, I think we need to, I'm trying to emphasize that given the multifocal nature of the disease and the different pathological features of all independent tumor foci, that have the largest tumor volume or the highest Gleason grade or extra prostatic extension. These all need to be considered in terms of making any diagnosis. So that is the important point that I would like to make. So that is for that, because that is the reason that we are actually using entirely different approach, which I will show you in the subsequent slide. So here I want to highlight the extent of the tumor heterogeneity. As I mentioned, that prostate is a highly morphologically heterogeneous and multifocal disease. So normally it takes about 10 to 15 years in the making of the prostate cancer with a combination of both environmental and genetic predisposition. Individual tumor foci are developed over a period of time. So when you take any prostate, the whole prostate, you will be able to see the tumors of different level, like some tumor may be just high-grade pin, some of them may be like a 3+3 early stage tumor, or you may find one or two tumor foci with a high Gleason grade, like 4+4 or or 5+3 or very high Gleason grade. So you will see all different type of tumor within a prostate with the different stages of development. So our goal is to understand whether the different tumors within a prostate, do they carry, all of them are genetically identical, carrying the same mutations? What is the interrelationship between the different tumor foci within a prostate, and which tumor is actually important to establish a metastatic disease like that? So these are some of the fundamental questions that are not clearly addressed in prostate cancer research. So the heterogeneity of this prostate cancer is the reason for this tumor's complex diagnosis and prognosis. Because any analysis, like I showed you before, if you're taking only a sample of one tumor foci, if we do some molecular analysis and make important decision, means we are conveniently ignoring an important information. So that is the reason we have to take the entire prostate into consideration for analysis, because of the clinical significance of some of the smaller or secondary tumors and the relationship between the extent of molecular changes and the metastatic potential of individual tumors is not clearly understood. So it is for that reason what we did. So like I showed you before, there are well-established molecular markers in prostate, like the ERT gene fusion, SPINK1 overexpression, and the PTEN loss, like that. So these are the well-established prostate cancer specific markers. The other important point that I would like to make is like this ERG, ETV1, ETV4, or ETV5 genes. These genes are expressed only when there is a chromosome translocations, because you are not dealing with the differential expression like it is expressed very low level in benign tumor and very high in the cancer. It is not like that. It is yes or no, because only when there is a chromosome translocation happens, these ERG, ETV1, ETV4 genes are expressed. So that means that clearly it is a somatic event that is specific for cancer, and you don't see any expression or not even a very basal level in the benign prostate. And the SPINK1 is also like that. Although it is not a gene fusion, for somehow it is expressed only in cancer tissue, but not in any of the benign tissue. So given this importance of the specificity of these molecular markers, we are using that to profile this entire prostate to address this tumor molecular heterogeneity. So we published work a couple of years ago showing that because our work is actually based on this first publication. So what we did was, in this study, we took the needle biopsies from the patients who undergo the standard 12-core needle biopsy. What we observed was, in some of the needle biopsy, so like I show you here, so in this one, so there is a large core, and you see like a two tumor foci from each end. This end there is a cancer, here another one there is a tumor foci. Or these two tumors are the same or different? Okay, so we want to address this issue. So what we call it as, when you see such a core, this is called discontinuous tumor foci, because they are not connected. We don't know whether it's coming from the same tumor or two different tumors. Because of the multifocal kind of tumor, we want to address this. So what we did was, we took about 97 needle biopsy cores from 80 patients with the spatially and discrete tumor foci. Okay, so they are, it's called discontinuous foci, and with a good cancer involvement. So what we did was, we used only the ERG and the SPINK1, because ERG is associated with about 50% of the prostate cancer, and the SPINK1 is found in about more than 10 to 15% of the prostate cancer. Because of the higher incidence, we selected these two markers to screen this. So what we found was, interestingly, like we found this heterogeneity. Either like one foci is positive for one marker and the other foci is negative, or one foci is positive for ERG and other foci is positive for SPINK1. Like that, we were able to show at least 13% of this biopsy cores are positive for, like one foci positive for ERG and other foci is positive for SPINK1, like that. So we showed this tumor heterogeneity with the presence of the two independent driver molecular aberration in two different foci. So this is the, this clearly encouraged us to look, instead of biopsy, to look at the entire prostate tumor, So if you are able to see this type of heterogeneity at the needle biopsy level itself, what we thought was, I think we can see even more complex pattern by looking at the entire prostate. Like in this slide, I show you, when you see this different morphological pattern in a given entire prostate tissue. So when we use these markers, so what we did was, instead of profiling this entire tissue with just one marker, what we did was we used a multiplex approach where we can screen at least more than 3 or 4 markers simultaneously to see what is happening in these different tumor foci. So like I highlighted before, because of the importance of these markers, we selected only the ERG, ETV1, ETV4, and the SPINK1, given the higher incidence of these molecular markers. Then we developed a systematic in a kind of strategy. We take only the whole mount specimen, not single biopsy. Then we have a systematic kind of scheme how to go over the screen of that. I will show you some examples. So here I'll show you. So this is the whole mount entire prostate tissue. So in this example, we clearly see there are 5 different tumor foci. Okay, so this is they call it the largest tumor foci, the so-called the dominant or the index foci, and there are at least 4 different small secondary foci. So when we subject these specimens with the ERG, ETV1, SPINK1, and ETV4, all 4 markers are actually screened on this specimen simultaneously. What we found was, like this tumor foci is completely negative for any of this marker. This foci is positive for ERG, and this is positive for SPINK1, and this foci is positive for ETV1 here. So here I want to actually, just clarify one point, that the ERG and SPINK1 are screened by immunohistochemistry because there are specific antibodies are available. But whereas for ETV1 and ETV4, we don't have a good antibody that is specific for this marker, because when you use some of the commercially available antibodies, they just stain everywhere. You don't see the cancer specificity. For that reason, we are using the RNA in situ hybridization by using the antisense oligonucleotide probes that is specific for this gene. And you can perform both IHC and RNA-ish on the same slide simultaneously. And you can observe the signal under bright field. So that is advantage of this approach. So here we clearly show that the presence of ERG, SPINK1, ETV1 in this tumor. But still we have at least two foci. We don't know what the molecular aberration is. So this clearly tells that these markers are expressed in a mutually exclusive manner. We did not find that none of these tumor foci is carrying more than one driver aberration in a given tumor foci. So these molecular markers are mutually exclusive. Like one is ERG, other one is SPINK1, other one is ETV1. And also it shows that because of the different Gleason grade, like this tumor foci is more like a 3+3. The other tumor foci that is ETV1 positive is like a 3+4, 7 high Gleason grade. And also we did the PTEN analysis on this tumor. We showed that the PTEN is deleted only in this tumor foci, but is intact in the other tumor foci. So which clearly shows the extent of the molecular heterogeneity of this prostate cancer. Then I will show you in the next slide. So here, I'm sure you will appreciate the dynamic nature of this tumor. As you can see, there is a foci. This is positive for ERG. This looks like a high-grade pin, and only this foci is positive for ERG. And right next to that, there is a gland right next to that. Even within this region, it is positive for SPINK1. And also, if you look at the spatial distribution of this tumor and the extent of this kind of the tumor distribution, that is positive for the SPINK1 positivity. So like I discussed before, if you are taking a sample from the needle biopsy or from a radical prostatectomy or for TMA, say for example, if you take a sampling from this region, you are going to miss all this information for this sample. So that is the reason I'm emphasizing the importance of looking at the prostate, using the whole mount radical prostatectomy rather than just a sampling of this. Because this is something unique to prostate cancer, this type of multifocal and presence of more than one driver molecular aberration in a given prostate. But I think very rarely it has been shown in lung cancer, like the ROS or RED gene fusions are present, two fusions present very rarely in a small subset. But in prostate, this is a common phenomenon. The multifocal nature is always there. More than 90% of the cases have multifocal tumor. If you screen these patients, you will find the presence of more than one molecular marker in a given patient. So here, then I will show you in the next slide. We were able to show even the presence of this multiple marker by using needle biopsy as well. And some of the cases, like I'm showing here two cases on the right side. On the left side, this is one case, and the left side is another case. We have three different cores coming from three different locations. This is right lateral base, right mid, and the right lateral apex, like that. And we showed that this foci is positive for ETV1, this is for ERG, and this is SPINK1. So what I'm showing is clearly we can capture this extent of this kind of tumor heterogeneity by doing this needle biopsy. And also, when we do needle biopsy, there is a possibility that when they do the standard 12-core biopsy, there is a possibility that some of the secondary foci may be missed. I think it is for that reason, I think most of the kind of urologists, they are considering doing a saturation biopsy, meaning that they can take up to more than 20 or 24 cores when they are doing this biopsy. So that they can hit the anterior region of the prostate, and also the small secondary foci can also be captured by doing the saturation biopsy rather than the 12-core needle biopsy. That will help to capture the extent of this tumor molecular heterogeneity in prostate cancer. Then I will show you what is the impact of these molecular markers and the heterogeneity in prostate in the subsequent slides. So before that, I want to emphasize the importance, because since these tumors are positive for one marker, and also when you look at the ERG, ETV1, ETV4, they belong to the same family of E26 transcription factor family of genes. There are about 27 genes within that family. Because of the high sequence kind of similarity, we thought that they may behave in the same way. But that is not the case. So what we show clearly is there is an independent clonal evolution of tumors with the distinct driver molecular aberrations. And some of the published work clearly show that the ERG and ETV1, they control a common transcriptional network, but largely in an opposite fashion. Okay, there are published papers in the literature. Anyone is interested, you can read that. What happens is ERG always negatively regulates the androgen receptor transcriptional program, but the ETV1 cooperates with the AR signaling by favoring activation of AR transcriptional program. And the ETV1 expression, but not the ERG, promotes autonomous testosterone production. And ETV1, but not ERG, upregulates expression of AR target genes, as well as genes involved in steroid biosynthesis and metabolism. And also, we show people are showing that ETV1 support development of invasive adenocarcinoma under the background of full PTEN loss. That makes the cancer more aggressive. So given that, so although, these genes belong to the same family, given the unique function, so it is important to recognize each individual tumor foci that are positive for specific molecular markers. All right. So next I will show you how we are seeing it. So I think this is the kind of the major issue that everyone is facing in kind of solid cancer because of the tumor heterogeneity. Here I'm using this this poster to highlight the point that I'm making, why the tumor, understanding this tumor heterogeneity is important. So in this example, I'm using the melanoma as an example. Here in this patient who's actually positive for a BRAF, the well-known, more than 70% of the melanoma are known to have this BRAF mutation, the canonical V600E mutation. And recently, drugs have been developed, that is PLX4032, targeting the mutant BRAF, not the wild-type BRAF. And initially, there was a big enthusiasm using this drug, and this patient was treated with this drug. After 15 weeks, the entire tumor is completely gone. We thought that this is a miracle drug that is going to completely cure melanoma. But unfortunately, within about 23 weeks after the treatment, the tumor relapsed, and the same locations, the tumor came back. So what it signifies is that this is the problem of this tumor heterogeneity, because this drug worked only on cells that carry this BRAF V600E mutation, but it did not work on other cells that do not carry the mutation. So these mutant positive cells are eliminated, but the secondary tumors without this mutation, they took over the tumor. That is the reason. So this is exactly the point that I'm trying to emphasize on the prostate cancer, given this multifocal nature and the multi-marker positive. So like in breast cancer, we talk about triple negative, in a breast cancer like that. But here, the same analogy, I'm saying that in prostate, these are all triple positive prostate cancer. We have the ERG, SPINK1, and ETV1. Okay, triple positive or dual positive or triple negative prostate cancer like that. So this is the new classification that we have to look into the prostate cancer. So based on our learning by using the needle biopsy and studying this tumor heterogeneity, we engaged in a large study, systematic study. We analyzed about 834 randomly selected whole monoradical prostate specimens, which is a rich resource that is available in the institution. So what we did was we took the ERG SPINK1, we profiled by IHC. Then on the same slide, we can do RNA-IST by using the ETV1 and ETV4 probes. And we analyzed about 834 tumors, okay? Then I will show you what we found. So out of these 834 cases, look at the table on the right side. So here, after the analysis of 800 cases, what we are finding is still about 17 or close to 20% of the whole monoradical specimens, we did not find not even a single tumor that is positive for any of these four markers, despite the presence of this. All these four markers account for about 60% of the prostate cancer, but still about 20% of the prostate, we did not find any tumor foci. Although these cases are multifocal prostate, none of them showed positivity for. So this is entirely a new subset. They completely lack any of this positivity. So this is an opportunity to discover some new molecular markers. Then another group, we found only the ERG is positive. Although they are multifocal, only one tumor foci that is positive for ERG, which is about 40%, mostly in Caucasian patients. And the another group, we found only SPINK1 is positive in one tumor foci or in a kind of two different foci. But here I want to emphasize another point. When we have this multifocal tumor, 3 or 4 tumors, we did not find out of these 834 cases, none of the cases showed that is positive for all the tumor foci with one marker. So always there is like 1 or 2 tumor foci that are negative for any of these 4 markers. Okay, so that is the extent of this heterogeneity. We did not find not even a single case that is positive for a single marker in all the tumor foci. So that is the important point that I want to emphasize. So another subset, we have the SPINK1 is positive, higher mostly in African American compared to the Caucasian. This is another group. Then we found another subset, about 17% of the African American carry both ERG and SPINK1. So here again, I want to emphasize that these markers are mutually exclusive. They are not present in the same tumor foci. Like out of these 3 or 4, multifocal tumor. One tumor is positive for ERK, and the other tumor is positive for SPINK1. Still, other tumors are negative. Then we found another group only positive for ETV1 alone, and ERG and ETV1, and the SPINK and ETV1. And then this is the interesting one, at least about 3% of the African Americans, we see ERG, SPINK1, and ETV1, 3 marker positive in 3 independent foci, and we have ETV4 alone. So this is clearly shows we identified entirely a new molecular subset of prostate cancer. So this is clearly shows the importance of analyzing the whole mount prostatectomy specimen rather than taking a sample of the prostate, so that you will be able to identify. The other important point that I want to mention here is we analyzed these 834 cases just by taking only one tissue sections because in the gross pathology, because of the prostate, it could be coming from the apex or mid region or the base region. They make multiple tissue blocks for each patient, at least 6 or 7 different blocks. So given the expenses involved and the what we did was we took only one of the tissue block that carry the dominant foci and also the secondary foci. So we analyzed even just only one tissue block, that itself giving this extent of this molecular heterogeneity. So our next goal is to, analyze each and every tissue block for each patient. And I'm sure we are going to identify most, if not all of the cases with always more than one marker like that. So that is another work that is going on. But at least I think I made this point here to emphasize that these are all the kind of situation. It's not always just one. If you're analyzing just one tumor foci, and if you find a marker positive or negative, and if you're making any clinical decision based on that, that clearly tells that we are conveniently ignoring some important information here. So here, this is another example to show that ERG is higher in African American, when the SPINK1 is much higher. ERG is much higher in Caucasian American samples, and the SPINK1 is very high in African American. This clearly shows the racial disparity in the incidence of these markers here again. Then also other important thing that we would like to show here. So we have among this 834 cases, and we studied another large group of radical prostatectomy specimens, more than like 2,000 cases. Here because both African American and Caucasian, they had the benefit of undergoing the radical prostatectomy. And when we looked at the biochemical recurrence-free survival rate for these cases after surgery, we showed that the African Americans are doing actually much better when compared to the Caucasian Americans. So given the benefit of treatment and other things, it seems, I think this is contrary to the conventional kind of belief that African American prostate cancer is highly aggressive and bad cancer. That may not be the case. If the African Americans are given the equal opportunity for early diagnosis and screening, I think they do much better when compared to the Caucasian American. This is a new finding, which because this is unpublished report, we are going to publish soon. So I think this is an important point that I would like to make. So then I want to, in the next few slides, I want to show you what we learned by doing this molecular profiling of this whole mount radical prostatectomy. So here I clearly show that the African Americans who are positive for the ETV4, which clearly, when you take into all other factors into consideration, what we found was that ETV4 is actually correlated with the worst recurrence-free survival. Because until now, there is always a controversy. Although these markers, the S gene fusions are discovered in 2005, even after 18 years, these markers did not reach the clinic. It is because in all of these years, all along, people are just analyzing only just a sample of the prostate. So we were able to see this important kind of finding just because we analyzed the whole mount prostatectomy, because the ETV4, it is not always present in the dominant foci. In most of the cases, we found the positivity of this tumor, whether it's a small tumor or large tumor, most of the time in the secondary foci, which were conveniently ignored in some of the previous analysis. Then similarly, we looked at the African American cases. What we found was the ETV1 positive cases are correlated with the worst recurrence-free survival for Caucasians, opposite to the African Americans. So which clearly shows that Like I said before, there is an independent function for these molecules, the ETV1 and ETV4, and they are functioning kind of differently in terms of outcome, both in the Caucasian. There is a racial disparity in terms of outcome for this marker. So this clearly emphasizes the importance of using these molecular markers in the screening of kind of prostate biopsy specimens. Like I showed you before, when we do the saturation biopsy, there is a possibility that you can capture all the tumor foci. When you profile these saturation biopsy samples with these markers, if you're able to identify the like ETV1 and ETV4 positive cases, and that will alert the clinicians to make some important clinical decisions in terms for treatment at the time of diagnosis itself, rather than allowing them to going for watchful waiting or active surveillance like that. And similarly, we showed that the lymph node metastasis, because some of the cases at the time of surgery, they have metastatic tumor in the lymph node. And we showed that the ETV4 associated, the African American samples, they are associated with the lymph node metastasis, but we don't see it in the Caucasian. And similarly, we found that the Gleason grade, the increasing Gleason grade in African Americans, because most of the patients in our clinic, they had multiple biopsies before radical prostatectomy. When we observed there is a change in Gleason grade from the first biopsy, second biopsy, third biopsy. When you look at all these biopsies, there is a change in Gleason grade, which clearly shows that there is an association that makes the cancer more aggressive like that. So with that, what are we doing next? Like I clearly showed, our focus right now is focus on the small subset, about 20% of the cases that are completely negative for any of these molecular markers, right? So for that, we have to come up with some new approaches, because the challenge is most of the prostate biopsy specimens are available in terms of paraffin-embedded tissue, like FFPE tissue. It's very difficult to collect fresh frozen kind of tissue resources. So we have a large collection of FFPE tissue. So we are looking for some improved methods for isolation of DNA and RNA, because as you know, the DNA integrity or RNA integrity is highly compromised in these FFPE tissues. So we are looking for some best methods that are commercially available, like the Beckman Coulter Life Sciences. They have come up with a best method for isolation of better quality DNA and RNA in these FFPE samples. And we subjected this approach in a small subset of African American cases. They are completely negative for all these molecular markers, and we subjected them for next-gen sequencing. And the sequencing data clearly shows that because of the high quality of the RNA that we obtained, when we compared the expression of the genes, when comparing with the TCGA data, because the TCGA mostly used fresh frozen tissues, not FFPE, we were able to get some comparable results between the FFPE and the fresh frozen. So we are actually more convinced by using this approach. And interestingly, we discovered a novel kind of gene fusions, because since we used only the African American sample, we found this rare and a unique gene fusion in a significant number of African American cases, the PCAT and the KCT involved gene. So I just put X because these are unpublished data. So we are working on this gene fusion, characterizing it, and we are going to screen in Caucasian as well to understand the true incidence of the gene fusion. So this is an important discovery, because here I want to emphasize the point, we are not sequencing samples just because the samples are available. We are carefully selecting cases based on their molecular profiling, because we selected only cases that are negative for all the known molecular markers. Right? They are not positive for ERG, ETV1, ETV4, SPINK1, or BRAF, any non-gene fusions. So when we carefully select these type of specimens, I think that will maximize the chances of discovering some new molecular markers. I think our approach paid off, and we have this new discovery, and which we are in the process of characterization. We will eventually get into publication in the near future. So with that, I would like to quickly summarize some of the important take-home messages that we learned from this work. So this, for the first time, I think I'm sure you will appreciate that this is the largest cohort of whole mount radical prostatectomy used for screening molecular markers. which clearly revealed unprecedented details on tumor heterogeneity with respect to molecular markers, clinical and pathological parameters, as you can see. So ours is the first study reporting the incidence of multiple molecular markers in a large cohort of prostate cancer from racial disparity perspective. Our study significantly differs from others because we have evaluated the whole prostate tissue instead of taking a sample like the dominant nodule alone. So the distinct molecular marker incidence in separate foci suggesting independent clonal evolution of tumors in a multifocal disease, because all the tumors are not kind of evolving simultaneously, but these are all independent clonal at different time point. And given that more than like 87% of the PC are multifocal, our results emphasize the importance of taking the secondary nodules into consideration when making treatment decisions. So distinct molecular subtypes and the pathological differences between Caucasian American and African American patients. I'm sure I think this study will prompt this type of analysis in other population as well to understand if there is any inherent differences between different populations. So reaffirming the racial disparity among prostate cancer cases. So different molecular subtypes may associate with distinct clinical and pathological outcomes, like we showed the association of ETV1 and ETV4 for worst recurrence survival between African American and the Caucasian. So this clearly emphasized the need for screening these molecular markers. So the molecular heterogeneity and racial disparity could be a major factor that dictate the overall response to treatment options and will have a considerable impact for targeted approaches for prostate cancer management. And the last few points, like I showed you, the ERG and SPINK1 IAC revealed entirely new distinct molecular subset, like presence of two dual positive or triple positive prostate cancer subtype. And technically, we can do both IHC and RNase on the same tissue for simultaneous evaluation of these markers. So our study is like one of the initial study, but now we have the latest technologies like the spatial transcriptomics and other things. Even you can add even more markers up to like 12 markers, or you can do the whole transcriptome like a 10x genomics using spatial transcriptomics. When you use approaches, I'm sure we will be able to learn even more about this extent of this molecular heterogeneity of this prostate cancer. And we clearly showed the distinct biology of S genes associated with prostate cancer between African American and Caucasians. And each disease class may require new therapies directed to underlying programs controlled by the S gene fusions. Even since these tumors are positive for more than 2 or 3 markers, it is important to have kind of drugs targeting all these markers. Even if you are having drug for one tumor foci that is positive for one marker, still the other tumor foci will take over, like the melanoma cases. So these are all some of the challenges that we are facing in terms of treating. And the other important work that we did is we looked at the matching lymph node biopsies in a multifocal case. We looked at the lymph node metastasis positive cancer with the whole mount specimen. Although these tumors are multifocal and multi-marker positive on the whole mount, what we found was on the lymph node met sample, only they are clonally distinct. Only one marker is positive on the lymph node metastatic samples. And it is coming from only one of the tumor. Out of the 4 or 5 tumors, only one of the tumor is actually escaping to establish this lymph node metastasis and other metastatic disease. So we have to understand, which tumor has the high metastatic potential to establish the disease. So I think these are all some of the kind of take-home messages. With this, I would like to acknowledge a large team of people who are involved in the study over a period of a long time. Particularly, I would like to thank Sharon Coxton, who is the research coordinator in my lab, who has done all this kind of hands-on work on the whole mode radical prostatectomy analysis, and Dr. Pinley, who did this excellent statistical analysis, and mainly the pathologists, Dr. Nilesh Gupta, Sean Williamson, and Dr. Tan Chitel. They have been very supportive of this, kind of tumor analysis and identification. And particularly, I would like to thank Dr. Craig Rogers, who is our current chairman of the Department of Urology, and previously Dr. Mani Menon, who actually hired me into the urology department. I would like to thank his support as well, and also different funding institutions for supporting this work. I think with that, I will stop this presentation and I will be happy to take any questions. Thank you.
Thank you, Nala. As a reminder to webinar participants, if you have a question, please type it into the Q&A box in the control panel. We'd also like to ask attendees to take a moment after the webinar's ended to take our exit survey and provide us with your feedback. We now have time for some questions, and the first one is, Nala, for multifocal prostate cancer tumors, did you find DNA SNP-driven foci and fusion-driven foci within the same tumor?
Now, can you please repeat the questions? I have difficulty in hearing you. Yeah.
Sure, sorry. For multifocal prostate cancer tumors, did you find DNA SNP-driven foci and fusion-driven foci within the same tumor?
No, like I showed you before, each tumor is kind of clonally distinct. Like one tumor is positive for like one gene fusion, the other tumor is positive for a different gene fusion. So these are clonally distinct. We did not find, very rarely, there is an exception for the rule. There are a couple of cases we found that more than one marker, like both ERG and SPINK1 present in the same foci. That I found like only 2 cases out of this 800. So since they are not a majority, I did not mention that. But rarely you will find those, but majority of them, I would say all of them are like clonally distinct.
You mentioned the use of RNA-ISH. How old are the whole amounts of tumor samples that can still give you good results if you tried? And do you intend to use the whole amount samples retrospectively?
Yes, because all these studies are done using the retrospective specimens. I think this is an important technical point that I would like to highlight for the benefit of all the people who are interested in using this. So I think when you are doing the RNA-ish, because the RNA stability will be compromised over a period of time. So in our analysis, all these whole mount specimens, they are all kind of sitting as a paraffin block, okay? And they are stored in room temperature. But for our analysis, we cut the sections just before doing the experiments. So most of these slides are actually within like 2 or 3 months old. So if you are allowing, but if you have already have slides cut, make sure that these slides are stored in at least -20 or higher temperature, just to protect the integrity of the RNA. But if any slides that are 6 months or older than 6 months, they are not useful for doing RNA-ish because RNA integrity is compromised. You may not be able to get the expected results. So you may end up getting some false and negative results. So please make sure you use some fresh cut sections. It is okay to use older blocks, even if they are 10 or 15 years old, but still make sure you cut the sections that are fresh and subject them for RNA-ish. They work beautifully.
How do you see spatial transcriptomics techniques aiding in the analysis of heterogeneity? Will these methods be a viable option for clinical use in the future, do you think?
Yeah, so like I said, so we have still so much to understand on this heterogeneity, the importance. So our study is just showing, just highlighting some of the significant aspects using only these 2 well-established markers. So when you use the spatial transcriptomics, either using like 10 markers or 12 markers or using the whole transcriptomics, I think it's going to dictate based on what you are going to learn from that, Again, so since you are going to do the unbiased analysis of this whole mount using the spatial transcriptomics, then you are going to see, you have to carefully analyze individual tumor foci. What are the differences that you are seeing in each tumor foci? Then based on the results, then that will dictate what will be the kind of outcome, how we are going to use that information for clinical purposes. But at least now we clearly show that these ETV1 and ETV4, they are well established kind of recurrent gene fusion in prostate cancer, and they are expressed only after chromosome translocations. So there is no expression in the benign. So these are all definite prostate-specific markers, and they are not present in any others. Like ERG is present in other leukemia and other sarcomas as well, but they have a different fusion partners. but the fusion that we are seeing in prostate is specific only for prostate. So these markers clearly tells, and also it is easy to screen also. We have good antibody or FISH or any methods. So this itself is giving important information because of its association with the what's the recurrence-free survival. I think this is an important step, or I would say the significant finding from our study. Yeah.
Well, that's all the time we have for today. We'd like to thank our speaker, Nalasivam Palasalami, and our sponsor, Beckman Coulter Life Sciences. If we didn't have time to get to your question, we will try to follow up with our experts. As a reminder, please look out for the survey after you log out to provide us with your feedback. If you missed any part of this webinar or would like to listen to it again, an archived version will be emailed to all attendees. Thank you for joining us for this genome webinar.